Okay, welcome back, everyone. This has, I think, been two incredible talks that have helped to kick off this workshop. Looking for Mia. There you are, Mia. Thank you so much for joining us. Dr. Shah is not going to be able to join us live this morning, but Mia Levy is here, and we're going to spend the next 15 minutes or so discussing issues and also thinking about ways forward. So Mia, I wanted to start out, you talked a little bit about this and so did Dr. Shah. You know, you're a cancer center director. Like all of us, you were thrown into this pandemic in March and had to make radical and rapid changes in the way that you provided care. How are we going to evaluate, though, going forward, what we want to hold on to, what we want to discard, and how are we going to make our environment support things that clearly are associated with better patient outcomes, more efficient care, more cost-effective care, and so on? How are we going to do that both at the local level and at the national level?
Oh, thank you, Larry. That's a wonderful question. You know, I think that there have been a number of evolutions in the course of the pandemic. The very quick shutdown with a rapid adoption of digital technologies for telehealth in particular, led to very rapid adoption quickly. But we were able to defer some in-person visits for a period of time during that, during those first critical few weeks. And then it became very clear as time went on that we needed to start seeing our patients back in person for various components of physical exam evaluations and performance status evaluations that can really be done much better in person. And so, you know, we've seen a shift as, especially in our state, you know, the rates are going down, and we've implemented all of our personal protective equipment. We've seen a decrease in the rate of utilization of telehealth. We're still using it to a certain extent in about 15 to 20% of our appointments. But the question really becomes, what is that optimal threshold that we should be looking for, you know, as the balance of use of telehealth and digital technologies in particular? I don't think we have an answer yet. And this is really where the utilization of scientific approaches to evaluate the impact of telehealth on cancer patients' outcomes becomes essential. We've all of our incentives to date have been aligned towards seeing patients in person. That has been the entire driving force of all the billing that has occurred. And yet we do a great deal of uncompensated digital health through telephone, typically in the past. And as we begin to see this reimbursement model change, there's a great deal of opportunity to start formally evaluating which types of appointments really should be done in person, and if there are any unintended consequences of not evaluating patients in person when aggressively trying to implement telehealth as a key strategy for patient care. So this is really uncharted territory because we were sort of thrust into it without the ability to evaluate these through prospective studies, and we have seen some increased utilization of our urgent care, for instance, as a result of telehealth, where patients haven't been evaluated by their physician and are now coming in for urgent care visits. I think the place where there's more opportunity in this regard is really in patient-reported outcomes. We see the long history of, not long history, it's really in the last 3 years or so, the which in today's pandemic world is actually pretty fast when you really think about it. It's a long time ago. 3 years ago, we had a randomized study, you know, with patient-reported outcomes and no patient-reported outcomes and showing a survival advantage. That is the gold standard of how we would like to test these digital interventions. And I think that we've shown, despite these amazing outcomes during which was like in, I want to say it was 2019 ASCO, and maybe 2018 ASCO was this big splash. We've had significant challenges for adopting it. The technologies aren't quite there. They're not quite fully integrated. The experiences at Memorial Sloan Kettering and Dana-Farber that were published so aggressively, it require an entire ecosystem and not just a piece of technology. It's an entire people, process, and technology to implement that successfully and show that it can be replicated in other environments. But we just haven't seen a reimbursement model that has enabled us to adopt that. These are some of our major challenges from a policy perspective, that we see a technology that can potentially decrease costs, increase the duration of treatment for patients, and increase their life expectancy. And yet we have no reimbursement model for it, and so it doesn't get adopted. So it's the digital health reimbursement platform. That probably needs to be our number one goal, is to see that those experiments come to play from a payer perspective, so that we can actually evaluate the true impact long-term on a larger population.
That's great, Mia. That's really helpful. And Ellen Baker from MD Anderson asked a question that's somewhat related to this. I know that we've experienced at Penn, and I suspect you have at Rush, that through the ability to do telehealth consultations, our super specialists were actually accessible to a broader population of patients who previously could not make the trip into Philadelphia or to Chicago, and in fact were likely not to make it at all, but we were able to provide initial consultation, work with their local oncologists, and help to design treatment plans. And we've actually found that our relationship with our community colleagues has grown closer through the pandemic. And this is a way potentially to share the high-level expertise that we have at some academic cancer centers with our colleagues who are in the community providing terrific care, but not really having the same type of access to all of us. So how do you see that really playing into this going forward? I mean, many of us view this, and I know many patients do, as an advantage. Is that going to be something we're going to want to hold on to?
I really thank you, Dr. Baker, for your question. It's an essential question, and I think that the biggest constraint we have right now is practicing across state lines. So we can do this if the patient is in the same state, is physically located in the same state as the provider's licenses at the time of the consultation. But we here in Chicago, Indiana is actually closer than some parts of Illinois, and we can't provide telehealth services as a second opinion for our Indiana patients. Because technically they're not physically located in the state of Illinois when our providers only have Illinois medical licenses. So I would love to see that particular issue from a policy perspective addressed, because Dr. Shulman, I think you're absolutely correct in stating that this is really an opportunity to open up access to patients for specialized second opinions without having to travel, especially during a time when travel has its own perils. But even in times when it doesn't, this has been a major lobby, but it's difficult to describe. It's almost like states want to keep it this way. And it's hard to say whether medical societies also want to keep the state restrictions this way, but we would really need to push forward to get all this changed at a national level, because our liability doesn't cover these scenarios.
So we've obviously seen the same thing at Penn, Mia, where we had waivers from many of our surrounding states during the height of the pandemic to provide second opinions, and those are starting to go away. And the other sort of complication of this is that there are different payer groups in different states. And they've been playing this out differently. So, one of the providers in New Jersey, which, like you, New Jersey is, like 5 blocks away from Philadelphia, just across the river. And yet one of their major payers was the first to start denying telehealth reimbursement. So It is complicated. And, I think that the whole issue of state autonomy in the way this is managed has more or less worked over many, many years that we've all been practicing. But I think, one of the questions we need to ask ourselves is, pandemics or other stresses bring out the weak points of our system. And, we need to try to learn from those. So, is there a way to have national will to make some of these things happen? Many European countries have been able to do this, but they're smaller. They have single payer systems. They have single EHRs. The U.S. is obviously very large with 50 states and the District of Columbia and lots of state autonomy. Do you view, through the FDA, through the national societies, a way forward in trying to change things at a national level, or we're just going to regress back to basically state managed regulations?
Well, I personally would love to see the evolution in our policies to allow for physicians to be able to practice across state lines with telehealth. It is a particular challenge that we have not been able to overcome for over a decade that we've been talking about telehealth. And, moments like this show our weaknesses and show that there is a driving consumer need, as well as a clinical need that is essential for patients to be able to get their optimal care, especially cancer patients who often is very appropriate to seek a second or third opinion. But these constraints that we have from state to state are really hindering our ability to do it. And I do believe there is collective will to push for telehealth parity. And now is the time. If we can't get something pushed through during a moment like this, we probably won't have much to go on as a better driving use case and a national imperative to do so.
Let's be optimistic about that. But I think, it may be one of the things that we need to think about after the workshop to try to figure out strategies to move forward. Ethan Bash, who will be speaking later in the workshop, and you quoted some of his work about PROs and survival benefits, makes the observation that PROs are just, they're all one-offs. We had a big PRO initiative at Penn, which actually was put on hold during the pandemic for some of the reasons that you mentioned. Patients were doing it on tablets in the waiting room, in clinic, which is not a feasible approach anymore. But what Ethan is asking, and sort of goes back to the same thing, can we sort of start to nationalize this, if you will, on standardizing how we collect PROs, how they're integrated into EHRs, what the basic qualities and metrics are for them, and help to push that nationally, just as the ONC has pushed the adoption of EHRs over the last decade or so. Can we do the same thing with PROs? We have growing evidence about how important they are. You've commented on that during your talk, but it's still sort of a mom and pop operation at each one of our institutions.
So some of the things that we're seeing is that the PRO vendors don't have a corpus of PRO templates to offer. They have the individual questions, but in a menu of 100 questions, how do you know the appropriate set of questions and the timing of delivering those questions to patients in various clinical contexts? And to date, that hasn't been fully evaluated in a systematic way for us to have the evidence base to understand which combination of questions is most likely to have the best impact, and at what frequency. You know, if you take a breast cancer patient, the questions you'd ask immediately post-op are going to be very different from the questions you're going to ask at cycle 3 of their adjuvant chemotherapy. And it will depend on the type of chemotherapy that they're getting, perhaps which side effects you're anticipating. And so what we see from the vendors is that they come in and they say, oh, we have an infinitely configurable system. And so now each system has to figure out how to configure that set of questions for their own particular circumstances, and each institution is making it up as they go. And we don't have a set of resources yet that are mature enough to really say that in the context of this particular clinical scenario, this is the best set of interventions to do from a digital health perspective to get the impact that was seen at another institution, and to be able to replicate that. And it also requires that you have a workforce that can receive those questions. You have to define what the thresholds are for when things need to be escalated in order to take action. And right now, we're all implementing those differently. If that continues, we're going to have, how can we know that we are going to have the same impact that they had at Memorial Sloan Kettering if we're really implementing a completely different system there in our institution?
So a lot of work to be done there. And as I know you are an incrementalist. We're not going to go from 0 to 60 on PROs or almost anything else that we do. But I think trying to accelerate their use would be great. I think you've spoken a lot about not only the importance before COVID, but many of us believe that PROs are even more important now, particularly as we're doing more of our healthcare remotely. Sybil Blau is going to be talking later on that, a lot of what we do, at least on the medical side, maybe not as much on the surgical side, though true there too, is counseling, and, that obviously can be done remotely as well as in person. But again, this sort of digital interchange with patients, whether it's telehealth or PROs or other methods, can help to facilitate that. And I think people like you who have, a cancer center, and, we need to figure out what studies need to be done to figure out what to carry forward, how to use this terrible pandemic that's upended all of our lives to at least come out with some things in medicine that are better than they were before. So I think that's our challenge. It's 10:30 Eastern time, and we are due for a break. And I'm going to thank Mia for joining us. Your talk was incredibly helpful and a great way to kick off the workshop, and your comments over the last 15 minutes have really just added to that. So thank you very much, and thank you for all that you're doing at your own cancer center and nationally. We're going to take a 15-minute break, and we're going to resume promptly at 10:45 Eastern time. Again, I know we have people listening in other time zones. And at that point, we'll start session 2, which is lightning round presentations, exemplars of novel digital health applications. So thank you, Mia, and we'll see everybody back in 15 minutes.